Hello and welcome everyone. Thank you so much for joining us. We'll be letting people in and we will be starting momentarily. All right, welcome. I see a lot of people joining us and continue joining us. So thank you so much for being here for our webinar today on DSM-5, TR, and substance use disorders with our presenter, Jennifer Haywood. Today's training is brought to you by the Great Lakes ATTC and SAMHSA. The Great Lakes ATTC and PTTC are funded by SAMHSA under the following cooperative agreements. The views expressed in this webinar are the views of the speaker and do not reflect the official position of DHHS or SAMHSA. The ATTC network uses affirming language to promote the promises of recovery by advancing evidence-based and culturally informed practices. A few housekeeping items for you. If you are having any technical issues, please individually message me, Alyssa Koala, in the chat, and I'd be happy to assist you. If you have any questions for the speaker, please utilize the Q&A section of your toolbar. It can help us stay organized as many questions may be flowing. If captions or the live transcript would be helpful, please locate that option using your Zoom toolbar. At the end of the presentation today, you will be redirected to a very short survey. Certificates of attendance will be sent out to all who attended today's session in full, and the recording and slides will be made available on our website by the end of the week. If you would like to stay connected with the Great Lakes ATTC, follow us on Facebook, check out our LinkedIn, our YouTube channel, or our podcast channel. And I'm excited to hand this over to our presenter, Jennifer Haywood.
Hello, everyone. I'm looking at the chat as some of you are checking in, and I keep seeing hello from Alaska. I think that's just so cool that we have people from all over the place. My name is Jennifer Haywood, and I'm going to share my slides in a minute while you all are checking in and saying hello. So tell us where you're saying hello from. It's really fun to see where everybody is located. I am in Columbus, Ohio. I am a social worker and an addiction specialist, and I'm trying to introduce myself and see where you guys are from at the same time. It's kind of fun. I have been a practicing clinical social worker in the Columbus, Ohio area since the mid-90s, which ages me tremendously, but I figure, let's just keep on going. So I've been around 30 years. I have a very unique story on how maybe it's not unique, but it's in the mid 90s, many people in the social work field, in my experience in Ohio, were not in the substance use disorders field. And back then we called it substance abuse, or substance dependence or alcoholism. All of the terms have changed over time. So back then, it was unusual for somebody without being in recovery or without any type of addiction family history to get into the area of substance. And I got into the area of substance by accident. I stumbled upon an internship at a rehab, and I was doing an independent study on this brand new term, dual diagnosis, which in 1995, it was a brand new term. And I was told you should do some interning on the addiction unit. And I fell in love with the population. And so I myself, I'm not in recovery. I do not have a family history, but it has turned into my passion. And so I always get extremely excited to train about what I love to do and what I do all of the time. So right now, I have a couple different jobs that I do. I am in Columbus, but I also travel to do trainings. But since COVID hit, we're all on screen much more than we ever have been. I have a private practice where I see about 15 clients a week, probably 80 to 90% substance use disorders or dual diagnosis clients. So I'm doing the clinical work every single day. I teach about it. I also I'm a full-time community lecturer at Ohio State, or The Ohio State University, where I've been in the social work program there since 2003. So very long time, and I teach diagnosis for the master's students. And I also teach a lot of addiction classes. And so today I get to combine those two expertise, and we get to talk about the DSM-5 TRs section on substance use disorders. So what I plan to focus on today is that section. So if you do have your DSM, there's 2 hours in the training, and make sure you guys ask the questions in the Q&A. But I just caught one in the chat. So this training is for 2 hours. I want you all to think about what your expectations are for today. And if you would like, we have between 300 and 600 people on this webinar, and I don't see any faces. So I'm just training in my own face. But if you would like, feel free to put right now any expectations or hopes that you would like to hear today in the 2 hours. What I plan on talking about is this section of the DSM and assessment. So we are going to talk about substance use disorders and how to start having a conversation with clients about substance use disorders under the umbrella of diagnosis and assessment. So we're focusing on the DSM today, but I'm going to throw in some assessment tools that I've developed over time in order to hopefully get more honest, open information from that first session, because all of us know that if we miss getting honest information about substance, we really do miss diagnosing, because we then miss if anything is substance induced. We miss dual diagnosis. We miss what is happening to their behaviors and their thoughts and their feelings and their emotions if there's a substance involved. And so I will be throwing in tips throughout the 2 hours on how to get some of that information. So we are not focusing on the updates today. That is not part of the training, but I will throw in some updates if they come to me. The TR does not have a ton of updates in the substance section. So we are gonna, it's really, if you know the DSM-5 that was in 2013 or 14, depending on your edition that you own, the substance section is pretty similar, but there are updates to the whole DSM-5 TR that could maybe change a little bit of your mental health diagnosis if we're talking about a dual diagnosis. So if anybody would like to put in the Q&A box any expectations, can you point out some of the bigger changes from the 4? So Natalie, from the 4 to the 5 is the biggest change in the substance use disorder section that we've ever seen. So I will be showing you all of the ways we diagnose now in the 5TR that are similar to the 5. Then I have Tiffany, substance use disorder diagnosis after no use in 12 months, and in MAT with no use in 12 months. Yes, we will talk about all of that. So this is awesome. I will work to simplify some of this for all of you. And the way I'll be answering the questions this morning is I'll talk for a little while, and I'm going to share the slides in a minute. And then you can, as you think of your questions, don't put them in the chat because I'll miss them. There's too many of you saying hi to me. Put them in the Q&A, and then I'll pause, and then I have Alyssa monitoring the Q&A to make sure I don't miss any questions. So I will, as soon as you think of a question, throw it in the Q&A, and then after maybe 10 minutes or after a slide, I'll take a pause, I'll look at my Q&A, and I'll keep moving, because otherwise there is just no way for me to see everything. Alyssa called it chat confetti. So what happens when you all keep asking us questions in the chat is they run so quickly, I miss them. So all of you that have put questions in the chat, throw them in the Q&A. I'm going to kind of ignore the chat, even though it's going against all my type A personality. Please do that. And I promise I will pause and answer them as we go. If I don't know the answer, I'll tell you I don't know, and I will tell you where we can look to get that answer later after the training. The training is being recorded. So throw those in the Q&A. And while people are throwing some initial hopes for the training in the Q&A, I would love to have Alyssa's going to do a fun little poll. It's kind of fun, but it's actually going to help me know where all of you are in your learning of the DSM, which helps me as a presenter. So I'm going to let her do the poll first, and then we're going to get started. So there's a poll. What version of the DSM did you first learn on? And I would love for everybody to, it's a one quick little poll question, and then it will give me some stats on who I am talking to today. Kimberly, the Q&A, just hover over the bar at the bottom of your screen, and where you see audio, video, participants, chat, react, share, you'll see Q&A. It's the toolbar. You'll have to hover your mouse down at the bottom. Awesome. Awesome, awesome. So everybody kind of have some fun, and let me see. I'm going to see who my people are today, and I'm going to take a peek at the Q&As. Shelly, I may not be able to present in a total client-focused manner, so it sounds like a conversation when it's a 600-person webinar without seeing faces, but I'm going to do my best. I will absolutely do my best. I love that idea. And Marina, the tools that I'm going to give absolutely will help with juveniles because I work with a ton of adolescents. So I will use some examples from my adolescent work. Awesome. Welcome, Floyd. Perfect, perfect. Okay, I took a peek. Hopefully all these expectations will be met. Oh my goodness. Some of you learned on the DSM-3. Hello, my people that have been around for a minute. That is amazing. So I personally learned on the 4. So I have actually not really taken a look at the 3 or the 3TR since my master's, my own master's degree many, many years ago. So it looks like the majority of you learned, well, the majority is 32%. So a lot of you are DSM-4 and on. Steve, I wasn't gonna call you old, but you said it. So yeah. You're older than I am. So I'm really glad I'm not the oldest in the room. Makes me feel good. Awesome. And then Katrina, yes, we will absolutely do a little bit of, when I talk about assessing substance, I do talk about how to ask questions in a way that might elicit information from somebody who doesn't want to talk to us, because most people who have substance issues definitely have a lot of shame and guilt and fear, and a lot of them are externally motivated to talk to us. And that's why this section of the DSM, I believe, is extremely hard to diagnose in, because often you are talking with someone who has an external reason for sitting in front of you, somebody from the outside, legal system, work system, relationship system. They're the people that said to the folks that you're talking to, you have to go get help. And the folks we're talking to are sitting there thinking, I got to figure out how to not tell them all the things. And so this is a challenging section to assess and diagnose in. And what we'll do is, as we go through the slides that I'm going to share in a second, I will throw in extras. So make sure the slides are really my guide, and they're not meant to be a entire training for 2 hours. They're meant to tip me off on my stories and my examples. So I will have stories and examples. I will pause to add extras. So I encourage all of you to have a notebook nearby to take some notes. I know that the slides will be available, but you definitely want to take some notes as we go along. If you happen to have the 5TR, I'm kind of like all blurred out, but it looks like this. It's a big, thick, shiny teal book. If you like my tabs, people always ask me where I got them. Amazon. I have tabs. If you do have this, you could follow along today. If you don't have it, it is okay. I have slides, you don't need it. But if you would like to follow along, you can. We're going to talk a little bit about coding today, but I don't want to land too much on the coding because, I mean, you can read on how to code. And so to me, I don't want to waste too much of our 2 hours talking about, dots and points and numbers. So we We won't talk too much about coding, but if somebody really has a question, we can deep dive into that a little bit. I think there was a 3TR. I'm pretty sure there was, but maybe there wasn't. I don't know, Dave. You might have caught our poll being maybe not perfect. And yes, a shout out to everyone who tabbed their own book. I will say, John reminded us before I get started, there is a free PDF that floats around the earth, and I have no clue how to get it, but my students know because students know everything. So if anybody knows how to download the free PDF of the DSM-5 TR, feel free to throw that in the chat, and we can give everybody the keys to the castle. I am old school. I'm 53 years old and I like a book. So don't give me a PDF to diagnose. I need to flip through pages as I'm talking to somebody. So whatever works for you is what works for me. Okay, so I am a very quick speaker. I talk pretty fast because I like to get as much stuff in as possible in our 2 hours together. If I need to slow down, please put that in the chat. Please ask me to repeat. I absolutely will. I will take time to pause so that we can answer questions. There is going to be a rhythm to this. So just kind of, get into the rhythm of how a webinar works when there's no faces. I like to get into the rhythm too. I get to see Jean and Alyssa's picture, but I'm really just talking to my own face and to my doggy. My pit bull's right next to me. Okay, so let me share my screen and we are going to get going. All right. Let me set things up so that I can open the chat for everybody. So I have a bad habit as a presenter of trying to answer questions and watch the chat as I go, but I know for a fact that won't work for me today with 600 of you. So I'm going to try to deal with my habit, but it is going to be really, really difficult for me to not look. So I'm really trying very hard to be a good girl and not stop and try to read the chat as I'm talking. So, be a little patient while I find my own rhythm and we will get to it. So awesome. Oh, thank you. See, I knew people would have resources on how to get that free PDF. So what we have in this section that changed from the 4TR to the 5 is when everything got turned upside down. We went from substance abuse and substance dependence to substance use disorder, mild, moderate, severe. And it turned everything upside down. And I think the substance community really got a little nervous because they thought, okay, we're no longer calling it dependency. Now we're calling it a use disorder. So you're going to, you can sense and see, and as you say it, a more person first language. So as the DSMs have changed over time, they're becoming more person first, more, there's more research on race, ethnicity, and culture. There is more hope for talking about the person that has this issue versus the person being an alcoholic or an addict. So we know those are two lay terms that never were in the DSM, but as we go through the DSMs, you'll see a lot of language differences and labeling differences. And as I talk today, even because I've been doing this 30 years, I am still working on changing my language. So I will tell you that there are lots of different people that still are in recovery that have been going to 12-step recovery for years that will say to me, Jennifer, I'm an alcoholic. I'm an alcoholic in recovery. Just call me an alcoholic. And I always say, well, you can call yourself an alcoholic, but if we're talking in clinical terms, it's alcohol use disorder. And they kind of chuckle a little bit, but I'm always mindful of the language and the labeling that is shifting because this is a section of the DSM that constantly has stigma attached because this is still respected and researched by the American Medical Association. They still call it as a disease of activation. It's a medical illness, but it's in the mental health book because the behaviors and the thoughts and the feelings of the emotions are the symptoms of this unique disease. And so the stigma comes from the way this disease shows itself is in behaviors that nobody likes. And so this is still a place of the DSM of a lot of shame, a lot of guilt. And I will say that I get a lot of clients that come to me that sometimes have a clinician that they've met with for a year or two, and they finally got brave enough to say, I think I'm drinking too much. And the clinician will send them to me because they'll say, I don't work with substance disorders. And so while I respect someone not working outside of their competency, I also really love when I get to train on this, so that I'm going to tell all of you, if you have somebody that finally says to you they're drinking, get some training and work with them, and don't send them to us quite yet, because they need you and they need your rapport that they have with you, and they finally got brave enough. And so I love teaching on this so that some of you who are not experts in this can feel brave enough and competent enough to continue to work with someone who finally can struggle. So, okay, so John just gave um, all of the dates for all of the DSMs. Thank you, John. That's super cool and exciting. And yes, the 5TR is 3 years ago, so 2022. So I'm so glad you're all here. In this new DSM, the best thing about the way it's set up, and it can be very intimidating because it's a very thick section. Every single drug, including alcohol, which we consider a drug, every single drug has its own mini section. And what is so great about that is in the old DSMs before the 5, they just had substance abuse and substance dependence. And then you had to plug in the drug and everything. And they didn't tell you what withdrawal looked like in every substance. And they didn't tell you what intoxication looked like in every substance. You had to look for all that somewhere else. This DSM hands it to you on a platter. So the way this section is set up is it has all the basics in the front, and then it reminds you everything in the front. You don't want to skip the narrative. What happens with us long-term seasoned professionals is a new DSM comes out and we skip reading all the words and we just go to the criteria list and we give people their F code and we move forward. I'm going to encourage all of you to read the narrative, because the narrative is where the coding is. The narrative talks about intoxication and withdrawal, which we never used to really think about or worry about in the old ones. And I'm going to talk about that today. And this one it reminds you to assess for substance-induced disorders and not assume that someone's sadness is clinical depression, because if someone's drinking, the sadness could be from the exact etiology of the alcohol, because alcohol is a depressant. So I'm going to kind of help you go through this section today and remind you to read the narrative, remind you to open up your DSM every time you diagnose, and don't open up that quick guide. Open up the big fat DSM and do it old school, because even I still don't know everything. And I teach this. Every time I read it, I'm like, oh my gosh, I missed that last time. And so I promise you, none of us know this whole DSM, even if we've been DSMing for a long time. So this section, substance and other addictive disorders, it includes gambling. We're going to focus on substance today. The reason it doesn't include the behavioral addictions is because the behavioral addictions, like internet addiction, and people call it lay term food addiction, but we really are going to look at binge eating disorder and shopping addiction and sex addiction. All of the behavioral addictions have not been researched to be in the same part of the brain as substance. So that's why you only see substance and gambling in the DSM. Everything else is in the to be researched area in the back of the DSM. It used to be substance abuse and dependence, and now we have mild, moderate, severe. So you want to think of substance issues on a continuum. And we're going to talk about today assessing for the red flags, because when you assess for the red flags, you are starting to get clues for whether or not the person sitting in front of you could have a substance disorder before they even talk about their own substance issues. So I'm going to weave in ways to ask questions about how to get information out of a client so that when you're in this section, you have the information you need to diagnose. So every tip that I give you today as we move along is going to feel very MI-like, because I'm an MI specialist, and most of how I talk to my substance clients, and any client for that matter, is in a motivational interviewing way. So you're going to hear motivational interviewing throughout this 2 hours also. So you get like a, 2-for-1 today, where I'm going to teach you some MI, because that's how I'm able to get the most honest information as possible from someone who is ready to keep things from me. So you want to assume that nobody is going to tell you the whole truth and nothing but the truth. And that's okay, because none of us tell our therapists on the first visit the whole truth and nothing but the truth. We don't trust them yet. So we don't get to expect that from our clients. So whenever somebody's withholding information from you, expect it, because they're waiting to see if you can be trusted. So that's what I want you to think about as we move into this section. You have to earn the right to hear about the substance stuff, and you have to ask the questions in the right way to hear about the substance stuff, because people are afraid to tell you because they're afraid you're going to send them to rehab. And so how do we pull the information we need to diagnose appropriately, and how do we code appropriately? So we're going to move through this section, and I'm going to throw in some of these tips. Okay, this is something kind of funky about the way we code. If the person sitting in front of you is actually under the influence in front of you, you are going to make sure you look at that substance's intoxication as a diagnosis first, because the reason we would give a diagnosis of alcohol intoxication is if someone's in my office and they're intoxicated. You don't give a diagnosis of alcohol intoxication if they've ever been intoxicated, because we know they obviously have if we're assessing for an alcohol use disorder. You only consider intoxication if they're under the influence in front of you. That's the same thing you do with withdrawal. So each mini section, like alcohol, cannabis, opioids, has its own list of diagnoses that you could possibly diagnose. The use disorder is the one that was the old abuse and dependence. That's one you're going to use the most. But if you're somebody who works in a place where someone could be drunk in front of you, you might consider coding for intoxication. If somebody is sitting in front of you and they are actively in withdrawal, not have they ever had withdrawal in the past. If they've had withdrawal in the past, that's one of the 11 criteria for a use disorder. I want to know if this person is actively in withdrawal in front of me. If they're in withdrawal in front of me, I would consider giving an F code for withdrawal. If you have figured out, and we'll talk more about this as we go, that this person is not only intoxicated, but they also have a use disorder, you're actually going to code it in one F code. If you have somebody that's actively in withdrawal and they also have a use disorder, you're going to code it with one F code. That's all talked about in the intro section of this DSM. I'm not going to go over exactly how to do that. I'm just going to tell you where to look for it, and I'm going to highlight the fact that we have to do that. If we were doing a 6-hour training, we would go step by step. We're doing 2 hours, so I want to move along a little bit. But I want you to be mindful that it's one code if they have intoxication and a use disorder. It's one code if they have withdrawal and a use disorder. The reason it's important to put that is because it shows an increase in acuity level, meaning if someone can't even stop drinking to meet with me, they're very ill and they will qualify for a higher level of care. And so if you're trying to get somebody to qualify for detox or qualify for residential and they're coded this way, they will absolutely get admitted because you're saying they're in withdrawal right now and they have a use disorder. Now, that means that someone could be intoxicated and not have a use disorder. Of course they could. Someone could drink and have a big oops and end up in front of me and they don't have a use disorder, they just had a big oops. Or somebody could be in withdrawal from their pain pills that they're not taking in an abusive way, but they couldn't get their prescription in time and now they're in withdrawal, but they don't have a use disorder. They're just somebody who's on it for pain. So we will talk about that today too. So just know if they are intoxicated in front of you and have a use disorder, or if they're withdrawal in front of you and have a use disorder, it's one code and it's talked about in the front of the section before you get to all the different drugs. I am going to pause and peek at the Q&A if I can find it. Q&A. Okay. Let me see. Looking at the Q&A. Do they have to confirm or admit they're under the influence? Erica, if it's quite obvious, like you smell alcohol coming out of their body, or they're slurring their speech, or they're sitting there and their hands are clammy and they're shaking, they don't have to admit it. If you can clinically assess, then that's really important. Peggy's asking for page numbers, starting at page 543, Peggy. How does seeing a client virtually affect our ability to accurately diagnose? That's a really interesting question, and I wish I could take more time with that because I'm so old school that I much rather see people in person. But I do know that opening up our world to virtual therapy sessions hits people that never would have come to therapy. So there's a lot of pros and cons for virtual for me, but I think that you could miss a few things on the first visit if it's virtual that maybe you wouldn't miss in person. But we're going to kind of do our best. We're going to do our best. Can you talk about engaging with the person coming in for an SBIRT screening when the person is more about joking around? Whomever asked about SBIRT screenings, can you put in the Q&A more about what that is? Because I don't know what those are. Okay. Most programs in Minnesota call themselves dual diagnosis, so co-occurring on trauma, but few seem effective or competent on the mental health aspect. So this is pretty common, Andrew. This has been since the beginning of time. Rehabs started calling themselves dual diagnosis in the mid-90s, and some of them do a good job at it, and someone just have one psychiatrist and they call themselves dual diagnosis. So it takes a lot of research. Now there are some rehabs that have trauma tracks, that have mental health sessions once a week. And I have a place in Cincinnati that I often refer my people to that have a specific track on trauma, and they are really good with the mental health piece too, but they are very heavily 12-step and CBT and DBT when it comes to the groups. And so you're right, it is really difficult sometimes to find one program for everything, but I even know a program in Florida now that does co-occurring eating disorder and substance. So the programs are trying to catch up with our needs, but you're right, it can be very, very hard to find something for someone who is sort of having a true dual diagnosis, and you don't want to send them to an old school rehab. Like, I get that. Initial screening. So when someone's doing that initial screening, okay, let me find it. So when the person's joking around, so we'll talk a little bit about assessment tools, and let's see if it answers your questions when I talk about how to ask questions if the person is joking around. So you might have to build rapport and talk with them before you do the screening. So if the screening has to be done before they know you, they're probably joking around because they're uncomfortable, there's no rapport yet, they're getting kind of stressed out. And so my just general feedback on that is you need a rapport before you do a screening. And so when we talk about, and I'll talk about this right now, and we're going to move to the next slide. When we talk about engaging that client and we start engaging, and our goal is to assess for a substance use disorder, it is really important to establish who you are, what your job is, and how much you're going to tell the person waiting in the waiting room that came with them. It's important for me to say, especially to adolescents, this is what I will share, this is what I won't share. It's important for me to say to court referred people, this is what I will tell your PO, this is what I won't tell your PO. It's important for people to know, one of the first things I say to people is, I will never tell you that you have to stop using substances. I will never tell you you have to. It is totally up to you on what you want to do when it comes to substance use, whether you want an abstinence-based session, whether you're looking at harm reduction. And, I use different language depending on different clients, but I always tell them it's their call on how they want to move forward. And so as soon as someone hears, and I'm not going to tell them what they have to do, you can see their shoulders go down and you can see the rapport starting, and that's going to be a person who's going to tell me more. So I tell a 15-year-old, I won't tell your parents about A, B, and C, but I will tell them if you're suicidal, homicidal, or you're about to use a substance that is so lethal that you and I will tell them together. I will never talk behind your back. I will never email your parents what happened in the session. Just know they can ask for your records, but in 30 years, I've never had a parent ask for the records. And just know that I will keep your privacy unless you and I have to talk together. I will tell somebody who comes from the court system, your probation officer only wants to know that you showed up and that you're doing what you're supposed to be doing. They won't hear about your private trauma history. They won't hear about the specifics of your substance use. They don't even have time to hear about that. That's my job. And so when you establish privacy, confidentiality, HIPAA, what your job is, what you will and won't make them do. Now, if you all are working, if one of you today is working in an abstinence-based rehab, then you'll tell them, say, hey, listen, this program does require abstinence. So while you're here, that's one of the rules. But just know it's always your call on whether or not you want to be here. And it's always your call on if when you leave, you want to go back to use. It's always your call. And when you use those MI engagement tools, then do the screening. And then perhaps they'll stop joking around because now they're going to realize that, okay, this person is on my team. They're going to do like this collaborative approach and they're going to work with me. And it works every time. You just watch someone, especially the young people, because they're ready to tell me a whole load of bull. And as soon as I'm like, yeah, this is private and I'm not going to tell you what to do, it's like I can't even write down fast enough my assessment. And so when you ground your client in a safe space and they hear you're not going to judge them, and I have had clients even start telling me when I start asking about the substance questions, we're going to talk about that at the end. When I start asking about substance use, I've heard clients will often say to me, oh my gosh, I don't understand why I'm telling you all this. I've never told anybody this before. And they kind of get scared of their own disclosure. And I always say to them, I'm like, you know what? I've been doing this a really long time. And my job is to help you figure out what's going to help you feel better. My job is not to judge you or figure out what you need to do for yourself. That's your call. I'm going to help you figure it out. We're going to do this together. And that collaborative approach, you even stick your DSM on your lap and say, we're going to look at this together. And I sometimes will even have clients help me self-diagnose. And as I'm teaching you all today how this continuum looks, what you're going to do is you're going to have them help you. You're going to say, okay, here's mild, here's moderate, here's severe. Where do you see yourself? And then they'll point. And then they're labeling themselves. And then this becomes this thing you're doing together instead of this one up, one down position. And this is how you gain the rapport to get the honest report to then find their internal motivation. And it works every time. I mean, sometimes there's a real, there's somebody who's real tough because they're really young, they're really angry, or they've never had somebody really hear and understand them before. So that may take a couple sessions, but just expect that your diagnosis might change. You might hear more on session 4. You might not get the whole tea the first session, and that's okay. That doesn't mean you're bad at this. It means the person's waiting to see if they can trust you. So you've got to lay it all on the line. I call it your 5-minute spiel. So it helps you feel like Peggy said, it like takes the load off your back. So now it's not your job to figure out what they should or shouldn't do. It's their job. And if someone said, well, I have to be here or I will go to jail, I usually say, well, I guess you're choosing not to go to jail and you're choosing to hang out with me. And sometimes if humor is appropriate, I'll say, I hope I'm better than jail. And then the rapport gets going. And so they're like, yeah, I guess you are. And they look around my office and they see my cool music posters and they see my arm sleeve of tattoos. And they're like, all right, she's not so bad. And use your strengths for that rapport. And that's going to help you every single time. So a lot of the drugs in this section, will have a list of 5 different diagnoses that you possibly can give somebody. Some of them have only 4, so you want to look carefully at the ones that don't have a use disorder, like caffeine. So for all of my caffeine lovers out there, guess what? Drink away. They took out caffeine dependence and they took out caffeine use disorder, but be careful. They might bring it back because they're doing research on it. Basically, they took it out of the use disorder section because we don't behave the same way when we're addicted to caffeine as we do when we're addicted to the other substances. So they didn't want it in the use disorder list. But you certainly can become physiologically dependent. And on this slide, I like to remind people that if we're doing a substance assessment, you got to ask about everything that's going in their body. So don't forget to ask about caffeine. Don't forget to ask about sugar. Don't forget to ask about food. And don't forget to ask about sleep. Don't forget to ask about nicotine. And don't forget to ask about smokeless tobacco because people will forget. People will talk about vaping and you're going to want to know what's in their vape because kids will talk about going to a smoke shop and getting weed. They're getting Delta 8. It's not weed. And so really, we're not doing like a little review on drugs today, but if you're somebody that's rusty on the substances themselves, you definitely want to get yourself a training on the substances that are typical in your area. So we have substance use disorder. That's the main diagnosis that you will use. Substance intoxication, substance withdrawal. And then when you see other, that is going to be used a little differently than when you see other in the mental health diagnoses section. So we'll land on that today a little bit. And then in the old DSMs before the 5, it was NOS, not otherwise specified. Now they've split up NOS and they have other and unspecified. I'm going to tell you this. Some people don't know this, and there's so many of you on here. I'm going to pretend like some of you don't know this. Unspecified is only used in emergency settings. It's only used if someone comes into an ER and they're intoxicated, but they're too either psychotic or suicidal or homicidal, or they're not accessible. You cannot assess them. And when you can't assess somebody, you give them an unspecified diagnosis so that you can give them an F code. And then after they come down, they're medicated, they're taken care of, then you do an assessment, you change the unspecified to another diagnosis. But unspecified is used in ER settings. So, really making sure you understand that I don't think I've ever used an unspecified diagnosis because I am not in an ER setting. I am in an outpatient setting. It looks like Eileen and Jeanette have really given a good referral for some of you. It's called Tall Cop Says Stop presentations. Super useful on keeping people in the latest drugs, delivery systems, and terminologies. Here in Ohio, we have a bunch of narcotics officers that go around and it's called Operation Street Smart. So find out in your area who is doing the trainings on substance. So now I'm jealous. I want to know who Tall Cop is. I want to hang out with him. Everyone's like, he's great. So cool. All right. So if somebody has a substance use disorder, there's 11 criteria. These 11 criteria are almost, I'm going to show them to you in a second. They're almost a true combination of the old abuse and dependence criteria from the 4TR, except there's a new one called craving. It was new in 2013. And then they combined 2 old ones. So they're very similar. If you learned on the old ones, the 11 criteria are similar. It's almost like we merged abuse and dependence and now we're calling it mild, moderate, severe. So the new one is called craving. Something very interesting. Thanks for the websites, everybody, for Tall Cop. Something kind of interesting about craving. Somebody asked me about 12 months in remission. And I will tell you all this. We are using person first language now, and something that has actually been taught to me because I was saying it a lot in a training and I had somebody call me out. We don't say clean and sober anymore because clean connotates as somebody using is dirty. And so I always like to do a disclaimer. If I say clean and sober, it's because I said it so long and I'm working on not saying it anymore. And I thought that was a very interesting thing to bring up to me. So just know, even if you're the expert, you're never the expert. There's always things we can learn. So I'm working really hard on my old language. So just as a disclaimer, if it comes out today, I'll probably correct myself. But I want to, when somebody is 12 months substance free, I used to say clean, okay? When somebody is 12 months drug free, thank you, Linda. When someone is 12 months drug free, that is called sustained full remission. There is an exception to craving because somebody who is 12 months drug free or longer, or alcohol free, substance free for longer than 12 months can still get a craving. you can crave 20 years in. And so even though remission usually demands that we haven't met any criteria at all for 12 months or longer, craving is an exception. You could crave off and on the rest of your life and still be considered in remission. So that's kind of like something funky that if you're someone who learned on an old DSM and you didn't quite read all the fine print of the new DSMs, you could have missed that one. So it's really important to read the fine print. Super important. Oh my gosh, we have people putting up free websites for the DSM, which is awesome. Thank you everybody for the resources. Whenever there's 300 people on a webinar, I always know there's somebody out there that's really good with the computer and you can like tell us all the things, right? So awesome. So each substance is discussed separately in the DSM, meaning the layout is drug and then the list of possible diagnoses, then course, prevalence, and criteria. In the old DSM, the course, the prevalence, and the criteria were all lumped under substance. Now your research under each drug is different for each drug. So now the course, prevalence, all of those stats are for opiates, are for alcohol. So it's so much more in tune with the actual substance instead of in general, which is super important because not all, I remember when I first got into the business, everybody would say, a drug is a drug is a drug. And I'm like, it sure isn't. Because if I'm working with someone who is shooting heroin into their arm, they are not the same as somebody smoking marijuana. Because the heroin person could die in a minute because the therapeutic index between getting high and being toxic is so thin and it could be laced with something. They absolutely are more lethal than someone smoking cannabis. So we can't go on that old drug is a drug is a drug. You have to look at each drug separately when you are, oh, that's not fair, Gina, that you're in bed, but whatever. I wish I was. It's not really fair. It's not really fair to say that a drug is a drug is a drug because each drug has its different likelihood of progressing to severe, its different time frame of progressing. It all progresses in a different pace and space, and it all depends on route of admission. It all depends on what the drug is that you're putting in your body because some are more addictive than others. And then it also depends on, I'm going to go backwards, 5 red flags that I'm going to teach you right now. So this is, when I talk about the red flags, and after I talk about the red flags, I'm going to pause and look at your questions. When I talk about the red flags, I feel like this tool is like one of the most powerful tools I've ever given groups of people. When somebody comes in and you can tell that they're withholding information or they're nervous or they're not sure or your rapport needs to get started, my best suggestion is when they come in and tell you the precipitating event to meeting with you, whether it's juvenile court, whether it's a rehab center, whether it's outpatient, doesn't matter what your setting is. Someone's sitting in front of you for the first time and you can tell that most of their soul doesn't want to be in front of you. After you say, tell me what brought you here, and they tell you the story, I want you to say, you know what? If you don't mind, ask permission. If you don't mind, can we put the reason you're here to the side? And I would just like to get to know you a little bit better first before we go into all the questions about what brought you here. And when you do that, that really, really helps them kind of relax into trusting you first. And I always say, put the substance questions from the middle to the end. So if you have an assessment tool that asks you to talk about what substances they're on in the first 5 minutes, move that tool to the end because nobody is going to tell you about any of that stuff till they know you. And so simply just moving the order of the assessment as you're gathering information really can help. I mean, when I figured this out, I was like, oh my gosh, I'm brilliant. I can't believe I didn't do this in the beginning. And so I start to get to know them. And what do people like to talk about first? Not them. They like to talk about other people first. So I might start with family questions. Tell me a little bit about, give me a 5-minute snapshot of how you grew up and where you grew up. And guess what? I start to hear about family history of substance without even asking. So that 5-minute snapshot of how and where you grew up it starts giving me information. It gives me trauma history information. It gives me where they grew up information. It gives me what school maybe they went to. It starts to tell me about their family constellation. Does mom drink? Does dad drink? And all of a sudden I'm getting all this info and I didn't even have to ask. And so as you start engaging them in areas of your assessment that maybe feel a little less threatening, you're going to start getting information without asking. Anything you can get without asking helps them feel a lot more comfortable. Eric said, I start with job, school, social stuff. Perfect. Amazing. That's what you should be doing. And then I want you to start gathering the red flags. So here are the red flags in a nutshell. And actually, I'm going to write them in the chat because I didn't do a slide on them and I probably should have. So I'm going to, if we were in, if there were 50 of you and I saw all your faces, I would have you guys guess the red flags. But since there's 300 of you, we're not going to play that game today. The first red flag that I'm going to share, I'm going to make the list and then I'll talk about them. I think that's the best way to do it. So let me just do the best way. Okay, almost there. This is just a quick list. Genetics, mental health, chronic pain, environment, trauma. Most of this list you can start assessing for before you ask about substance questions. I call the red flags assessing around the use. That's just something I call it. I'm going to assess around the use first. That's going to help build rapport. And then I'm going to assess for the use, middle to last. And Carly says I always move it to the middle to the end. There are some things, yeah. Sometimes you're at a place where you have to ask some things before and, just do your 5-minute spiel before you get into the questions, and that might help. So when we talk about genetics, I just listed the red flags in the chat. So I'm going to talk about each one of them. So don't worry. We're not going to go fast. So number 1 on the list, really? It doesn't show? That's weird. Okay. Well, I'm going to start with the first one. The first one is genetics. If somebody has a genetic predisposition for addiction, that is a major red flag. And let me tell you how I ask that question. When they're talking about their family, I might say, anyone in your family, aunts, uncles, cousins, grandparents, parents, you feel like maybe drink alcohol, maybe more than social use, or have any type of drug issue in their lifetime, kind of ask it like that. You don't want to say any alcoholics or addicts in your family. Like, you want to be careful of labels. But assess about their family before you ask about them, because a lot of people are super comfortable asking about their family or telling you about their family. Oh yeah, grandma drank like, I don't know, a fifth a day. But she wasn't an alcoholic. Like, that was just grandma. Like, because when you use terms, sometimes you're going to miss self-report because no one ever thinks of grandma as an alcoholic. They just think of grandma drinking a fifth a day. Like, they're not going to connect behavior to terms. So, Jean just put the red flags in the chat, you guys, because for whatever reason, when I wrote in the chat, you didn't see it. It's like, I'm like a ghost in the wind. I don't know why. So first is genetics. So let me give you the tips. If somebody has one parent, one biological parent, if someone is adopted, this is harder to do. One biological parent that has a substance use disorder, they are 50% more likely than somebody with no parents with a substance use disorder to develop a substance use disorder. Sometimes I actually teach the clients the red flags. And I say, okay, let's talk a little bit about like if we get to the point of talking about whether they have a use disorder and they look at me and they're like, I don't really know if I do. I'm like, okay, let's talk about the red flags and let's talk about what criteria you relate to and we'll figure it out together. So if you have two parents that have substance use disorders, you are 80 to 90% more likely to develop a substance use disorder. So genetics is powerful. That doesn't mean that you can't develop a substance use disorder without the genetics. You still could, but you'd have to pick the right drug, like a really addicted drug, and you'd have to use a lot of it, I always say you have to work really hard to progress to a use disorder if you don't have the genetics, or you have to pick a drug that is highly addictive and use it a lot. So I do not have any red flags for substance use disorders, but if I picked up crystal meth, I have a 1 in 30 chance of getting addicted after the first use. So I should not pick up crystal meth. But if I pick up a margarita, it's pretty likely I'm going to be okay. Unless I have other red flags that start to get me. So let's just keep talking. So we've got 2 red flags. So Paula, we're going to get there. We're going to get there. So great. Yep. Yep. Absolutely. We're going to get to trauma. So trauma is one of the red flags. Absolutely. So sometimes we don't really ever know who has that genetic predisposition because it's not a genetic link, it's a genetic predisposition. But if there's drinking in the family, you could just kind of think in your head they might have the genetics. Awesome point. Then we have, let's do red flag number 2 is a mental health diagnosis, depression, anxiety, ADHD, schizophrenia, eating disorder. If you have a mental health diagnosis, and it doesn't have to be previously diagnosed, it could just be mental health symptoms, and somebody is using a substance in a way that they would explain as self-medicating, then they're going to use more and more and more to get the same effect, to get the same relief, and they're going to build a tolerance, and it's going to push progression. So if I'm depressed and I'm drinking to feel better, even if I don't have the genetics, it might push progression. If I have bipolar and I'm drinking to come down off a manic episode, but then I'm using a stimulant to come up when I'm sad, then I'm going to progress a little quicker. I call it pushing progression. So anytime somebody is not treated, medicated, helped for a mental health diagnosis, and they're using their own substances to treat their mental health diagnosis, that can be a part of what makes it more likely that they could develop a use disorder. So just having a mental health diagnosis could give them a red flag. I have actually, this is anecdotal and clinical. This is not research. So disclaimer, every single adolescent male that I have, and I get a lot of adolescent males. I don't get as many adolescent females in my practice. I like to joke that like the girls are better at hiding it, but the boys all get caught. So that's a little joke. So I see a lot more males than females. But if I have an adolescent male who is using cannabis on a daily basis, and they say to me, you know, Jennifer, no one even noticed for a year I was smoking weed because it was actually helping me do my work. You better believe they're ADHD. I mean, that's anecdotal and clinical. That's not researched. But I always say to them, any ADHD diagnosis when you were younger? Oh, yeah, I'm ADHD, but I won't take medicine for it. And it's like ding, ding, ding. And so you can see how, because cannabis this is what I call it, it causes pseudo-stability. It actually helps people before it hurts them. That's why we have medical cards, right? There is a therapeutic and medical effect of cannabis. When you have somebody who's using it for their ADHD, it works until it doesn't, until it backfires. And I always say to those young kids, I'm really sorry it backfired on you. It probably worked until it didn't. And they're like, yep, you're right. It worked until it didn't. And so you will start to notice that people with mental health diagnoses often they use more. And sometimes at first it helps, and that tricks them into thinking they should keep doing it, and it pushes progression. Another red flag is environment. What environment is this person in? Is this person in an environment or a culture that drinks a lot? Like, I grew up in a family that didn't drink much. Like, we didn't have alcohol at our family functions, like maybe a couple bottles of wine, and people didn't really open them. It was like, oh, is someone going to drink this? No. But some people grow up and it's just kind of what you do. Or what high school environment is this kid in? Sometimes I will ask a high school kid, hey, tell me what kind of drugs roll around your school. Like, you know, different high schools have different personalities. Some high schools have more opiates, some have more alcohol, and they're like, oh, there's opiates all over our school. And all of a sudden I'm getting information before I'm asking them about them. And so it helps me walk into that rapport. And so what's the environment like? Things are really accessible now to young people. So that environment is a red flag. Then we have chronic pain as a red flag. If people have chronic pain and they're prescribed an opiate and they use it as prescribed and they never abuse it and they never use on top of it, they will still develop physiological tolerance and they will still have physiological withdrawal if they ever go off of it. And in the opiate section, it gives you rules and tips on how to figure that out. So if someone has chronic pain, they definitely will develop those two criteria. But unless they're abusing it or using on top of it, they don't get a use disorder diagnosis unless they do what I call jumping the line. Sometimes that chronic pain client has depression, has anxiety, and they start using more than they should. And then, their doctor cuts them off and they go to the streets and then they drink more and then they progress. So chronic pain is a red flag. And then the last one is trauma. I always say, when I do a decision tree for diagnosis, before you give somebody any other diagnosis, you want to rule out trauma. And when somebody has a trauma history, that could be a piece of the puzzle of progressing to a use disorder, because why wouldn't I self-medicate if I've been through what I've been through? And so those of you that have written in the chat about generational trauma, absolutely, that is a red flag. So whether or not it's genetics or trauma, we may not know. We don't really have to have a good list at first, but as you're assessing someone and asking them about their family and about their mental health history and about have they ever been in the hospital for suicidal ideation, and tell me about your environment and tell me about your hobbies and tell me about, as you're assessing all that, I'm telling you, you're assessing around the substance. So by the time you get to the substance, you're going to know a good amount about the likelihood of a use disorder even before you get to that. It allows for rapport building and it allows for you to have some clues, because we need clues. Two other red flags I'm going to tell you right now are age of onset. So age of first time, not they took a sip, but age of first regular use is really, really important. It's really important to remember that age of first regular use, the younger you use, the more likely you'll develop a use disorder. The other red flag is drug of choice. If I got somebody with no red flags, so if I got an 18-year-old, they got no red flags, they got caught drinking at prom, you can better believe that that's probably an oops. They just got caught. They're just a dumb kid maybe. And everybody kind of drinks at prom and they got caught. Or what if I get an 18-year-old who drank at prom that has 5 red flags and that drinking is part of daily drinking? Now I have a different 18-year-old who got caught at prom. And so the red flags help you assess around a typical story. How do we figure out if somebody in college has a use disorder? Because I don't know, I think back to what I did in college and I don't know, I almost was trying to figure out how to get one. I mean, we all kind of did some things in college. Well, the difference is look at the red flags. Are these episodic behaviors to check out the college environment? Or is this somebody who has enough red flags that you have to start lifting an eyebrow? Different drugs, different likelihood of progression. So if you have an 18-year-old with no red flags and drinking is how they got caught, slower progression with alcohol, they probably don't have a use disorder. But if you have an 18-year-old who got caught and they're snorting cocaine and they like opiates and they like benzos and their grandparent has a substance issue and they have depression, well, we're in business here. And so those red flags give you some clues. Epigenetics would be part of the multi-generational impact of trauma. Yes, even the person, even if they don't have trauma themselves, any trauma in the family could contribute to a use disorder. You're absolutely right. So I've been peeking at the chat a little bit, but right now I think it's important that I get to the questions as I pause. Thank you, all of my trauma experts. I am EMDR trained 5 years ago, and I'm learning more and more about, as I train in other areas, how to throw trauma in, but it's not quite my expertise. So I appreciate all of you jumping in and helping me on that one. Okay. Someone asked, you said intoxication and use disorder is one code and withdrawal is one code. It's not the same code. It just means I want you to you're going to combine intoxication and use disorder into one code instead of having 2 codes, one for intoxication, one for use disorder. You're going to combine into one code withdrawal and use disorder, but you're going to list the 2, but you're going to combine it when you code it. So there'll be one F code, but two listed. I hope that helps. And then I used to work on the National Survey of Health and Stress, and they found that if you have a domestic violence history, there's an 86% correlation with significant substance. Wow. So Eileen, there are a lot of substance treatment centers that have trauma tracks now. And I wonder if you're ODMH certified or if you're saying you're a dual diagnosis program, I wonder if that's why they're creating trauma tracks now. I have a statistic from Stephanie Covington. It's 70 to 99% of women with substance use disorders have a coexisting trauma diagnosis or trauma history. 70 to 99% of women with a use disorder have a coexisting trauma history. So trauma is big. Think about our veterans that saw combat. Think about sexual abuse, physical abuse, domestic violence. Think about anything, and it doesn't have to be PTSD trauma. It could be anything people explain as traumatic for them. PTSD takes a certain list of criteria, but if someone says this was traumatic for me, that's their personal experience, and it could be under the umbrella of the trauma red flag. So, awesome. Eileen, EMDR is magical. It is magical. I am so glad I finally learned how to do it. I felt like it was so missing from my practice. I learned how to do EMDR January and March of 2020, right under the wire. COVID hit like 2 days after I was in a room with 100 people. And I'm like, wow, I know how to treat trauma now that the world is traumatized. This is so convenient. But it has come in handy now with my substance clients, and it's been pretty magical. Okay. So vaping is not handled under the DSM. It's just the substance that's in the vape is how you diagnose. But the route of admission can influence the progression to a use disorder. So if somebody is taking a pill, that's different than crushing and snorting a pill, which is then different than combining it in a solution and shooting a pill. So if someone tells you, well, I crush and snort pills, that's a red flag for progression to a use disorder. So any substance can be used any way. What if the client says there's no history of mental illness in the family? Yes, there's absolutely mental health questions, Catherine, as we get to them later. You know, I'm kind of highlighting just how to ask about substance today, but there'll be a section on your assessment to ask about. What I'll say to people is, even if you've never been officially diagnosed, do you feel like you might have depression or anxiety or symptoms that you feel like are being helped by drinking? So I'll ask it in a lot of different ways. Catherine asked, does sustained remission have to be verified by a negative drug and alcohol screen through the year? I think, Catherine, it depends on the type of treatment you're doing. You know, if you're keeping somebody from like treatment in lieu of conviction, or somebody, if they use again, might have to go to jail, then they might need drug screens to prove it. But I just do outpatient private practice, so I just trust the client. If they're 1 year, we call it 1 year. Just know that if someone is in sustained full remission and you're still doing therapy, you better have another diagnosis to bill for, because remission won't get paid. If you just make sure there's a mental health diagnosis that you're billing for. A lot of us addiction specialists won't add the remission specifier. We'll just keep it use disorder because we want to make sure we keep getting paid. So just kind of be aware of that too. Awesome. And Laura said drug of choice. Yeah, so drug of choice matters when it comes to progressing to use disorder. Combining drugs matter. So finding out drug of choice, finding out rite of admission, finding out age of onset, and finding out the red flags all starts aiding us as we move into looking at the 11 criteria that we're going to look at in a minute. Paula said, my sister and I made a conscious decision to stop the intergenerational trauma. Today, both my nieces are clean and sober, mid-30s. One is a doctor, the other has her own business. That is what recovery can look like. We did whatever we needed to do. You just gave me chills up my arms. I know that I'm trying not to look at the chat, but I'm really glad I looked at the chat because it's awesome. I'm telling you, those stories keep me going. I have people who are 13 years in recovery that still hang out with me once a month because I'm part of their program. And it reminds us that like recovery can happen. I think there are two sides to this work. Side one is there is a lot of relapse, and it's the nature of the illness. It's just someone becoming symptomatic again of what's going on in their brain. It's just like someone who has depression becoming depressed again. And we don't shame people for becoming depressed again when they have depression. And we don't shame people for having anxiety again because we've treated them and they should be unanxious now. But for some reason, relapse has become this big shaming thing. And so remembering that people could use again, and if you're that safe space to tell about it, you get to be the safe space to help them get back on. And so I don't even think about use and non-use as a thing anymore. I think about, is your life better? Is your life healthier? Are you still talking about it? Are you still coming in for help? Let's move forward. And so, everybody's putting their recovery time. This is so cool in the chat. I can't see everybody's and I can't get to everybody's, but I just want to let you all know, whoever is in recovery on here and all your years, it's amazing. Congrats to everyone. And for people who've worked hard to break the cycle of their own, difficult family systems. It can be really tough. A lot of us say, like, I'm going to do this differently. And then you hear old stuff coming out of your mouth, and it can feel automatic sometimes. So, oh, it's so good. Ugh, stop it. This is so good. Okay, so we're not taking a formal break because it's only 2 hours. I do feel like some of you will have to take a break, and that's okay. Just step away and come back. And so feel free to keep sharing all your recovery on the chat while I get all choked up as I'm trying to train, because that's what happens to me. I'm a big sap. I feel like this is passion. This is not work. And that's also why I only see 15 clients a week and I teach a lot. So the way I sustain my energy around work that can get very hard and difficult is I do a lot of different things. I don't just do therapy. So find a way to sustain that energy and passion. You may not be somebody who can see 30 people a week, and that's okay. I definitely am not. Okay. Oh my gosh. So these are so many amazing stories. Keep the stories coming and read each other's stories as I keep talking. I wish that we had time for me to kind of look through all of them. Okay. So as you turn through, I'm going to highlight on page 547, you'll see recording procedures. That's the page 547. That's the page where it will teach you all that weird coding that I was mentioning before. And then I want you to make sure, if you haven't read it before, you read the narrative on page 548, because that's going to talk about substance-induced disorders. So as I show you the list on this screen of the different sections, the mini sections under the umbrella of addictions, I want you to remember that anytime we are assessing from anybody, their mental health symptoms and their substance symptoms, our brains have to start going towards, are their mental health symptoms from the drug, substance induced, etiologically linked? Or did the clinical mental health condition come first and they self-medicated and now they have both? So let me explain the difference in a nutshell. Okay, in a nutshell, if someone has alcohol-induced depression, it means the central nervous system depressant, alcohol, sat on their serotonin, made them sad, and now that the alcohol's gone, the sad is gone. The substance made it happen, and when the substance is gone, the depression's gone. That's the kind we all hope people have, because as they choose to stop using, you see the mental health symptoms lift. You don't have to treat both. You just have to treat the substance. If any of you have ever worked in a rehab setting, you see it right before your eyes. They stop drinking or stop using other drugs, and within a few weeks, they're rocking and rolling. They're like, got my big book, going to AA, rock. I mean, they might still be honeymooning, but we'll let them. But their depression is lifted. Their anxiety is lifted. And it's like, okay, all that was either substance induced, or this is not clinical. I just call it crappy life depression. So many things, bad things have happened because of their behaviors. They're just not okay. And the crappy life depression is not a diagnosis, but that will lift. You're also thinking in your mind about Which came first, chicken or egg? You're thinking in your mind, did this person have depression at age 10 and then the substance was used to help them feel better? Because that person has a dual diagnosis. That person has a clinical depression diagnosis and a use disorder sitting right next to each other. And as they work on the use disorder, we have to work on the depression at the exact same time. In the mid 90s, we started seeing psych units look at substance and substance units look at psych because we realized we can't do parallel treatment. We got to do integrated treatment. We got to treat them both at the same time. One is not more important than the other. Someone wants to work on their depression while they're still drinking. It's not ideal. It's not ideal, but they still want to work with you. And so if you're in a position to do harm reduction, you will. If you're in a position where you can only do abstinence, that's what you'll say, hey, I'm in an abstinence-based program. I'm going to send you to someone who'll do harm reduction with you. And you got to make sure they're an expert because as you reduce alcohol, it can be really dangerous, right? And so we used to say, sorry, we can't treat you until you get rid of the substance because that substance has to be gone and then we can treat your mental health. But now we got to meet people where they're at. And so if someone isn't willing to stop using, but they want to work on their mental health, we got to find a way. If someone is ready to stop using substances, that's more ideal. We hope that someone's willing to be abstinent so that that mental health can really be figured out. Like, okay, did it come first or did it not? Sometimes when you're doing an assessment, they will be a good historian, and they'll be able to say to you, yep, anxiety runs in my family. I was diagnosed with an anxiety disorder when I was 12. And yes, I self-medicate with alcohol. And yes, I have both. And that is the type of person that hands it to you on a platter. It's like, ta-da. But if you have somebody that was adopted or somebody that doesn't remember their childhood or somebody that doesn't want to talk about their childhood, sometimes you can't figure out what came first. And so you can confidently give them a use disorder if they meet criteria out of the 11 criteria. And then what you'll do is you'll watch the rest. So maybe you'll say, rule out depressive disorder, other. Or maybe you'll say, rule out alcohol-induced depression. Or you'll rule something out or you'll watch something. And sometimes it changes over time because then we finally figured out we change. You can change diagnoses. It just takes a clinical update form that your agency has. So, I'm going to keep going. This is the list of substances. These are the categories that are in the DSM. And each one of these substances has a different list of diagnoses that you could diagnose them with. All of them have use disorders except caffeine. We have alcohol, cannabis, hallucinogens. You are allowed to specifically write the type. So you could say LSD use disorder. You could say heroin use disorder. So you don't have to put, oh, sorry, that's on opiates. You can say LSD use disorder for hallucinogen. You can say psilocybin use disorder for hallucinogens. That way you can show the specific substance. So you're allowed to put the specific substance. The code might be the same for hallucinogens, but you're allowed to pick the specific drug. Inhalants, you want to be specific because one inhalant is not like the rest. And again, I want to refer you to the Tall Cop or Operation Street Smart. If you Google list of inhalants, man, are you going to find 4 or 5 pages of inhalants. It is absolutely unbelievable. It's pages and pages and pages. And so knowing the exact inhalant is really important. Inhalants, I believe, is a shortened list. And if we peek at it right now, it's on page 601. Inhalants don't have any withdrawal because if you're using enough inhalants to you will die before you would get to a point where you're so tolerant you could actually withdraw. Inhalants are so toxic, nobody is able to withdraw from them. You don't live long enough. That's how lethal they are. So I see in the chat people are chatting a little bit. Jasmine said, I have clients who don't resonate with the conventional idea of recovery. I usually explain that making a daily decision to try to be a better human is recovery. I love that. Somebody was referring to Jasmine's chat and I felt like I just couldn't ignore it. So I had to see. So, you know what I like to say, Jasmine? I like to say everybody has a different recovery puzzle and everybody's pieces to their recovery puzzle look different. Some people have to click in depression meds. Some people have to click in AA. Some people click in church, and everybody's puzzle looks different. But when somebody's struggling, we got to look at your puzzle again and see if we're missing something. And it helps all of us like become detectives together. And instead of saying, you know, use or relapse is a bad thing, I always say use or relapse is information. I said, it's just information that we got to figure out, you know, what to do. And usually I'll do a strength-based comment if somebody uses or relapses, and I might say, okay, so you were able to be abstinent for 6 months. So you know how to do it. You know how to do it. So let's figure out what went right for 6 months. And they get so surprised when I use like strength-based talk. Like, let's figure out what went right for 6 months. And then you know what? We're going to get to what went wrong by accident. And I'm not going to have to say, well, let's figure out, you know, what you did to make you use. Instead, I just say what went right. And then they're like, you know what? I was going to a lot more meetings then. And then I let that slip. And I was exercising then, and then I let that slip. I think I figured out what's going on. I just stopped doing what was working. And I'm like, okay, so we know what to do now. But let's make sure your puzzle is sustainable. Because if you're trying to do all the things all the days, like I'm real careful with that 90 meetings in 90 days stuff, because that's sometimes not sustainable. And then people will get so frustrated that they can't do that role that they won't go to any. And so, really being open to allowing somebody to create their puzzle is really important. And then maybe people won't be so afraid to talk to you about substance use. So, pre-lapse to a relapse, what went right? Yeah, I love, and there are many pathways to recovery. It all looks different, but they're all healing. And so, when I have somebody say, Jennifer, I don't know if I could commit to never using again, I said, it's a really good thing that that's not something that you're ever going to be asked. Or let's just figure out how to do things differently today. And I said, even if you ever decide to go to an AA meeting, it's always just one day. And I always tell them, I kind of use, my clients know I'm not in recovery because they ask, and I tell them I'm not. And I always say, you know what? If everybody lived like people who are in recovery lived, mindfully, paying attention to triggers, paying attention to doing the next right thing, all of that lingo that they love, then the world would be a much better place. So I always tell them, I learn a lot from you on how I can do things one day at a time. And so, you know, really recognizing that recovery should not be just for people who are trying not to use substances. Recovery from an eating disorder, recovery from everything. And so kind of really paying attention to all of how we use language and how we talk to people. All of this goes into assessing and diagnosing. And the cool thing is the DSM-5 TR wants us to be this way. If you go to psychiatry.org, and if Alyssa or Jean can put it in the chat, since the chat doesn't like me. If you go to psychiatry.org and you click on fact sheets, the fact sheets are going to tell you all the newest, coolest things about the TR in detail. And it's going to tell you the deep dive that the TR has done into language, into labeling, into more research on racism and discrimination. And you're going to see that in the substance section. So it's in the chat. Please click on it. That's going to really help. So here are your sections. In the substance section, the other diagnosis is used a little bit differently than the way we use other in the other sections of the DSM. The other section is used if somebody is using a substance in a use disorder way, but the substance isn't listed in the DSM. It's for like the stuff that doesn't have a space. And so if you go to that page, it's a super interesting page. It's in the back. It's hold hold on. I had it marked once and then I didn't have it marked again. This is my new DSM. Okay, 652. I just got a new one, so this one's not marked. On page 652, flip the page to 654 and mark it. We're not going to land here too long, but mark it for later. It's going to give you an entire paragraph of substances that aren't listed here on my screen. So, yes, somebody can be addicted or have a use disorder to a steroid or to, I don't know, nitrous oxide, whippets, for those of us that were around in the original Grateful Dead times, whippets. And this is, I always like to say when I train on this, page 654 is the proof that you got to read the narrative, because look at all this good stuff in here that you might have skipped if you're just somebody who likes to look at the criteria. So it looks like kratom is pretty big in Maine. Yeah, kratom is super funky. Somehow it still can be sold in smoke shops, but it's so unbelievably addictive. Yeah, it's really something. So really being sort of the additional training to this training is being up on the substances that are in your area and being trained on them. And know that you'll be trained like today, and then in 3 years, your training's outdated. Maybe even in a year, it's outdated. I have probably been to, I don't know, 20 Operation Street Smart in my lifetime. So you can't stay in the know. All right, so I'm gonna go, hold please. So here's the list. Remember to ask about smokeless tobacco. I had somebody whose life and marriage was becoming absolutely ruined by those little packets that he put in his lip, and his teeth were being ruined. So even though in the substance world, we sometimes downplay nicotine, like, okay, we want to do one thing at a time. It's okay if you still smoke cigarettes. And that's totally fine. I kind of agree. If somebody wants to wait to deal with nicotine, that's fine. On the other hand, sometimes the nicotine goes so up in recovery that it becomes dangerous, and it can ruin relationships. And this situation was, um, the the wife was going to leave the husband because of the pouch in his mouth. And so we can't downplay nicotine like we have in the past with use disorders. But yes, if someone's not ready to do that, then of course we'll wait. Now, I will tell you, oh my gosh, I have been doing more nicotine cessation with adolescents in the last few years than I ever have before since vaping came on the scene. Now that you can do it so easily, they are using up to a pack to 2 packs a day without realizing it. And it is a hot mess express trying to get these kiddos off nicotine, especially because nicotine is researched to be one of the hardest substances to get off of, harder than cocaine. So yeah, you're absolutely right. Okay. Oh, that's interesting. Hold on. I know I'm looking at the chat and I'm not supposed to, but I am. I don't care. If you stop nicotine at the same time as other substances, you're 4 times more likely to remain abstinent. That's so interesting, Jeanette. Thank you. This is so interesting. Yeah, kratom is all over the place. True, true, true. Vapes are easier for kids to hide. Absolutely. Yeah, this is, wow. Yeah. Okay, we're all here together on this. Okay. Just a quick little example with caffeine. I had a nurse come see me many years ago, and it was one of those drug-free workplace screenings where I don't know what I think for fentanyl, they might be putting it under sedative hypnotics, but I'm not sure. We'll have to look up fentanyl and see where it goes. But I had a nurse come in and she got caught with a positive drug screen for cannabinoids. She had to come see me because she's a nurse, she's in trouble. And she told me she had so many sleep problems and she had to use marijuana to sleep. And of course, we were going to get into that. but only somebody who works with substance use disorders, I'm not going to say only, I'm going to guess that it's probably those of us that do would notice her 1 liter Mountain Dew sitting next to her. And so I just sort of assumed that she drank more than one, which that's an addiction specialist, right? I don't know that any other typical mental health only therapist would have even noticed her drink sitting next to her. But I asked her, I said, how many of those do you typically drink in a day? And she said 4. 4 liters of Mountain Dew. A nurse. And I want to be like, I just cocked my head and I said, I think I found your sleeping problem. And so this is just a quick little funny little blurb about like we can't underestimate some of the substances that we don't like focus hard on, but caffeine matters, tobacco matters, they matter. And so at the very end of the slideshow today, and I'm mindful of the time, so we might have to start cooking. At the very end, I'm going to give you some tips on how to ask about some of these, because if you don't ask, they're not telling. If someone comes in and says, I have a drinking problem, and you don't ask about other substances, they could be using other substances, but they're going to omit. It's very easy to omit. It's very hard to withhold information by commission. So we're going to talk about that as we go. So I'm just going to do a quick peek at fentanyl. I don't know if any of you code fentanyl and you can tell us where it goes. Yeah, it goes under, it says, it goes under opiate related disorders and poisoning by synthetic narcotics. It goes under opioids. So I just did a quick Google search. I could be totally off and wrong, but that's what the quick Google search told me. Shelley said, I experienced a caffeine-induced psychosis with a client. She hadn't eaten all day. Oh, wow. So yeah, being very, very aware. So it looks like opioid use disorder is where we're going to code fentanyl. That was my knee-jerk reaction, but I wanted to look first. So thank you, everybody. So when you code, you can actually say cocaine use disorder if you want. The code will be the same as crystal meth, but you can actually label it with the actual drug of choice so that the drug of choice is clear when you're diagnosing. Okay. Everybody read the chat on your own because people have really great specific examples, but since there's 300 of you, I can't read all of them. All right. So I'm mindful of the time and I really want to get to my tips on how to ask the questions about the actual drugs. So I might go through the next slides just a little quicker than you'd like. And, you know, you can ding me on the evals, but, you know, be kind. But I'm really trying to prioritize in a 2-hour time period what would be the best. So let me see. So let's look at, so all of the use disorders have the same 11 criteria. They all have the same 11 criteria. So substances often taken in larger amounts over a longer period of time than was intended. This is when someone says, I promised myself I would not close down the bar and I closed down the bar. I promised myself I would only have 3 and I had 10. So this has to be happening over the previous 12 months. So in the last 12 months, that's what you're asking questions about, the last 12 months. You're not asking lifetime questions, okay? There are no longer criteria for legal. There used to be a legal criteria in the abuse section of the 4TR. They don't have that anymore. If someone had 6 DUIs 8 years ago, that's not in the criteria. But I promise you, if they've had 6 DUIs 8 years ago, they meet other criteria. Don't worry. They're drinking enough that they're going to show up. So don't worry. The second one is there is a persistent desire or unsuccessful effort to cut down or control. It says alcohol. I'm just using alcohol as an example. This is the one over time, not over a day. So this is when somebody says, you know, I did sober January because everybody around me was doing it. And then everybody else just stayed sober because it felt good, but I went right back February 1st. Like I could not stay stopped. Like I've been trying to stop for a long time. Or they'll switch drugs. They'll switch drugs. They'll go from one drug to another. So they stopped, but now they cross addicted. So really pay attention to that. A great deal of time is spent in activities necessary to obtain or recover or use from the effects. I call this like the 24-hour user. You're either using it, you're recovering from it, or you're in withdrawal from it. Craving or a strong desire or urge to use. That isn't the newer one in the 5. That's the exception to the remission rule. Reoccurrent use resulting in a failure to fulfill major role obligations at work, school, or home. Usually somebody meets that earlier on in the progression and then goes to important social, occupational, recreational activities are given up or reduced. That's like later on, probably, it all deteriorates. Continued use despite having persistent or reoccurrent social or interpersonal problems caused or exacerbated by the effects. So the people in your life, they're not the same. They're worried about you. Reoccurrent use in situations in which it is physically hazardous. So drinking and driving in the last 12 months, working on heavy machinery in the last 12 months, doing things that are physically hazardous under the influence. Use is continued despite knowledge of having a persistent, hold on, I have your chat in the way, a persistent or reoccurrent physical problem. So this is when a doctor says, your liver is a hot mess, please stop drinking. And you're like, you know what, I'm not quite ready. Or you know what, your depression meds. This is also psychological. So your depression meds, someone says, I have a client's wife who keeps drinking on her lithium and she can't stop drinking. And it's like, it's now time to look at this as a huge issue that we have to look at. And then it's physical or psychological problem. And then we have tolerance, needing more and more to get the same effect, and withdrawal, experiencing symptoms when you cannot use anymore. So tolerance can be a decreased tolerance with alcohol. If you don't know what that means if your liver is so damaged from drinking for so many years, you might have been someone that could drink 10 drinks, but now you can only drink one and you're drunk. And that's when your liver's damaged. So older clients sometimes will have decreased tolerance. Withdrawal symptoms, different from hangovers, right? So withdrawal symptoms are when you have used so much that your body physiologically and or psychologically needs the drug to feel normal. And if you don't have it, you get sick. And then if you use the drug to be not sick, we call that relief use. That is withdrawal. You check this one if someone's ever been in withdrawal. You give them an additional diagnosis of withdrawal if they're in withdrawal in front of you now. So if someone has an alcohol use disorder and they meet 6 out of 11 criteria severe, and they're currently in front of you, intoxicated or in withdrawal, you're going to give them that additional diagnosis, and it's 1 F code, but 2 diagnoses. Okay, I'm going to give you all I'm going to go backwards and give you a really interesting tip that not every trainer does a tip on, but because I've trained in so many DSMs, this is what I want you to do. And then I'm going to pause and look at the questions. So, Paula, Jeremy, I said, you can ding me if you feel like I went too fast, but I'm trying to prioritize what I'm talking about. And Jeremy's saying he's not going to ding me. He can tell I'm on track. So that's what he's talking about. So when you look at these 11 criteria, everybody in the substance use world got a little wonky and bent out of shape because they had to go from abuse or dependence to use disorder, mild, moderate, severe. Abuse used to mean you could probably train them into drinking again. And dependence used to mean too late, they probably should be in recovery. Then we got mild, moderate, severe, and everybody's like, what's moderate? And so what I do is I give you tips on which old criteria were dependence and which were old abuse. So if you look at this list, the first 3 criteria, you can put a little D. They were the old dependence criteria. Okay? Craving is new. Reoccurrent use is the old abuse criteria. So there's a little A next to it. And then continued use despite having persistent recurrent interpersonal, it's an old That's an old abuse. So put a little A by it. And then important social, occupational, recreational activities given up or reduced. That's an old dependence. Put a little D by it. Reoccurrent use in situations physically hazardous. Put a little A by it. Old abuse. Next one, put a little D. And the next two, put a little D. You should have 3 A's. Okay. You should have 7 D's and 1 new. If someone meets 3 A's and 1 D, they have moderate, that might be someone who's more abuse leaning. Like, all right, maybe they could control alcohol again. If someone has 4 D's, they're more dependence leaning. Okay, so when we have moderate, people have said to me, how do we treat moderate? Because we know severe is probably someone who should be in recovery, and we know mild is probably someone who isn't so bad yet. But what do we do with moderate? And I always say, look at the criteria they meet and see where they're leaning. And at the end of the day, it's what they want anyway. So what I would educate the client, psychoed, I would say, you're kind of abuse leaning, which means if you want to try to control your alcohol use, we could give it a go. Or I might say, you're kind of dependence leaning. So we can give it a shot, but in all likelihood, you might have to consider stopping because you meet enough criteria that it might be hard to control. And that way, now you have this way to use the DSM as a psychoed tool. And sometimes I will say to my clients, where do you put yourself? As I'm checking off criteria in my head, I have them, I'll go like this and say mild, moderate, severe. And they sometimes will give themselves worse than I would give them. All right, I'm pausing to get to my questions. Q&A. All right. Let me see what I can get to, and then I'm going to pop to my screen that I really want to train on. What are we saying instead of relapse now? I think if someone's doing 12-step work, relapse is perfectly fine. But what I will say to them, Tiffany, is, sometimes there's a lot of problem-focused language in AA, even though I am very pro 12-step. I mean, 12-step is like the free support. I want people to go if they fit. But sometimes I'll say to my clients, sometimes when you go to a meeting and someone relapses and someone else says, oh, all your days have to start over, that's pretty problem focused. And I want to tell you, in session with me, you don't lose all those months. So I still use the word relapse, but I talk about it in a different way. And I think that really helps people. Erica's asking, have I ever come across a client that only had a substance use disorder with no co-occurring mental health disorder? Oh, Erica, that is the $1 million question, isn't it? Yes, rarely. I remember being trained as a 23-year-old social work student, and my supervisor, who was 12 years in recovery, she would joke with me about this, and she would say in the mid-90s, honey, you get real lucky if you can find yourself a plain old alcoholic, but there really aren't any plain old alcoholics anymore. And that was in the 90s. And so I think what we're recognizing is that everybody who has a substance use disorder may not have an official co-occurring diagnosis, but their depression is up, their anxiety is up, their life is struggling. And so they still have all the same stuff. Maybe it's not official 2 diagnoses. And maybe you got to wait to figure out if it's substance induced or not. So yes, the answer is yes, it can happen. But man, I feel like people don't get help until they have a lot going on. It's like if we could just catch people when it's only substance, wouldn't that be great? But since we shame people into getting help, they don't get help when it's early. They get help when they're depressed and anxious and traumatized and all of the things. So, and yes, Juliana, it doesn't necessarily have to be diagnosed. It can definitely just be those feelings and symptoms. And someone said there's a difference between a lapse and a relapse. So some people use those 2 terms differently. So make sure you all are looking in the chat because everybody is weighing in on some of your questions. So read the chat for your peers' answers while I go to the next one. Is there a good way to parse out information when talking with someone who has a thought disorder? Oh, those are a little bit different. That it's not effectively treated. Sometimes delusional thinking can make it very hard to understand what's a result of substance. Sometimes it's nearly impossible to know what is substance induced and what isn't until the substance is cleared out. And so when somebody is hospitalized, that's our chance to clear out the substance to see what comes back. Especially, and we got to use collateral information. We need family members and friends, if we can find them, to tell us, does a psychotic disorder run in the family, or do we think this is LSD induced? So that can be really tough. Talked about rule outs. I've been cautioned about using this. Is this an insurance issue? Peggy, insurance does not need to see the rule outs because the rule outs are not an F code. The rule outs are your notes to yourself. This is what I need to watch. So I wouldn't give an F code to a rule out F code. I would just give a rule out written out diagnosis in your assessment tool to watch. And then F code and bill the one you definitely see, and have your own notes about what you're ruling out, but not a code for the insurance company, because insurances won't pay for rule outs. So that's how I would navigate that. Our insurance is paying for SUD outpatient for tobacco use nowadays. That's a really good question. I have one client that only has a tobacco diagnosis and it is getting paid. But I'm going to tell you right now, Tiffany, depends on the insurance. I have a client that I've treated for 3 years for gambling addiction, and her new insurance won't take gambling addiction, but they'll let me give her an anxiety disorder. And I'm like, really? Okay. So there's no way I can answer that question. The only way I can answer it is you have to see what happens. And if they don't accept it, you have to see what else you can give them. Cocaine and meth might not, I don't know. I have to look up and see. That's a really good question. Cocaine and meth might, I'm under the impression that all amphetamines are the same code, but that maybe could have changed since I have looked. So let's look together. So I'm looking under stimulant. Stimulant. Oh, I think you're right. Wait. Cocaine and amphetamine are different. You're right. Thank you for the clarification. Thanks all. Okay, if we are not looking at past symptoms, then a person could go from severe to a mild if their symptoms decrease due to monitoring through the legal system. That seems counterintuitive since someone with the past severe diagnosis have different risks. The way the DSM works is we are assessing within the last 12 months. That's the way we're not assessing within lifetime. But the good news is if somebody needs help, they are going to have a diagnosis that is billable. And sometimes it just might not be the one that you're treating right now. But that's the way the substance section works, is in the past 12 months. What if someone has a history of substance use, nothing recent? How do you diagnose that? So I don't diagnose, you can diagnose it as in sustained full remission, Deborah. But if you're billing right now for therapy right now, you probably have to give another diagnosis like anxiety or depression. How do you work with people who have been incarcerated for 5 years and qualified for dependence prior to going in and need treatment? There is a code for that, Brenda. So there is a specifier where you can give them a use disorder, and then it tells you like under a contained environment or something. And that way you can bill for it. Okay. I got to pause on the questions for now. I might get to the rest, I might not, but I got in controlled environment. Thank you, John. Thank you. Okay. So let's keep going. 2 to 3 criteria mild, 4 to 5 moderate, 6 severe. And then things to note regarding specifics. So for opioids and sedative hypnotics, there's rules. So when I want to point out 2 different things, and then I got to go through something real quick because we're going to end soon. So when you look under opioids, I want to point something out. Okay. This is for opioids and it's for sedative hypnotics. So opioids like a pain pill, or sedative hypnotics like Ativan, Xanax, Valium. If you look under opioid use disorder, you are going to see under tolerance and withdrawal. Now I can't find it. You're going to see under tolerance and withdrawal rules. If somebody is under medical supervision for pain and they are getting prescribed opioids and they're not using more than prescribed, they're doing everything they're told, they still will meet criteria for tolerance and withdrawal because it physiologically is going to happen. My mom, back pain client, no red flags for use disorder. She was on opiates 4 months, way too long, and she went through tolerance and withdrawal. She does not have a use disorder because she was doing everything right and her body just went through tolerance and withdrawal. If you need to assess that same person for a use disorder, you can't count tolerance or withdrawal in your 11 criteria. You have to move them to the side, and now you have to assess based on the last 9. Based on the last 9, do they meet 2 to 3, 4 to 5, 6, and up? You basically are not allowed to count tolerance and withdrawal for pain clients taking their pain meds. Then we have the same with sedative hypnotics. So if someone's taking Ativan the way they were prescribed, when you assess for a use disorder, you have to take away tolerance and withdrawal and then assess for a use disorder based on the last 9. Then that lets you know if either of those substances do what I call jump the line. It's called jump the line. Okay, so, all right. I just explained everything I'm telling you ahead of time. There are also special specifiers for someone who's on methadone maintenance or Suboxone or Vivitrol. You can have a specifier for that. Look under opiates. Okay, so I want to go through this list pretty quickly. I already taught you about the red flags. So when you assess for substance, you're all going to have your screening tools and all the things that you do. I'm going to give you an additional tool if you want to add it or use it. You're going to make a list of all the substances that are in your area, You're going to start with alcohol, cannabis, nicotine, because those are the less scary ones to ask about. And you're going to do something pretty cool. You're going to have the list. It could be on 1 page, 2 page, 3 pages. And what you're going to ask is, this is the first thing you're going to ask. It's a very specific strategy. And the strategy is you're going to ask yes and no questions. So I'm going to put alcohol to the side right now, and let's talk about the rest of the list. What you're going to say to the client is, hey, I go through this list with everybody. Can you just give me a yes or a no on whether or not you've ever tried it, experimented with it, used it, if it's ever come up for you? And use the word experimented with. That word disarms them from worrying about, oh, there's the pit bull. He lasted almost 2 hours. Hold on. Go ahead, baby. That word, that experiment word, is going to disarm the person from being worried about giving you information because nobody's afraid to tell you if they tried something. Oh yeah, I tried it once. This helps us with information they're withholding by omission. So you're just going to pop down the list. Yes, no, close-ended questions, nothing you were ever taught. We're always taught open-ended. So close-ended questions. Yes, no, yes, no, yes, no, yes, no. Go back to the yeses. Hey, you told me you've experimented with ecstasy. Have any idea, how many times you've ever experimented with it before? And I had someone say, about 40 times. And I was like, what? I didn't do that. But in my head, I was like, what? So either I was able to catch something she wasn't going to tell me, or maybe she thinks 40 times is experimenting and her friends have done it 500 times. But this asking about experimenting and going yes and no, and then going back again and asking about how much, oh my gosh, it's golden. I've had students email me 10 years later. I still use that list and I'm finding out more than I ever wanted to know, Jennifer. So the warning is, if you do this technique, you're going to find out more than you ever wanted to know, and then you're going to have to figure out what to do with it because now you have a list of 6 things instead of 1. When you diagnose more than 1 item, you have to list them. We have gotten rid of polysubstance dependence. Every drug is diagnosed separately. Assume everyone drinks. So instead of asking about, do you drink? Just say, hey, can you let me know an idea of how much you drink through the week? And when you assume everyone drinks, it's allowing them to believe that drinking is no big deal. I also might ask, what's your favorite? If that feels appropriate. Like you don't want to ask what's your favorite if someone is saying, you know, I'm drowning. You don't want to be like, what's your favorite? But if someone doesn't want to really talk to you and they're like, I just drink beer every night, I might say, hey, what's your favorite? What's your go-to if you don't want to use the word favorite? And then you might find out it's IPAs and not Bud Light. And that's a really different list, isn't it? And so this list, and then if you want to, you can ask age of first use. And that, do the list at the middle or the end. And that gives you more information than you ever would have known in the past. So I'm going to stop sharing so I can easily peek at my last questions before it's too, I'm mindful of the time. So I'm going to get to as many as I possibly can. The list of dependence and abuse again from the DSM criteria. Yes, let's go back. So, okay. So Elizabeth, the list is the first three are dependence, craving is new, reoccurrent is abuse, continued use despite social is abuse, important social occupational is dependence, reoccurrent use is abuse, using the last one is dependence, and the last two are dependence. The only three abuse are reoccurrent, social, and reoccurrent. So the two reoccurrence and the social are abuse. There you go. So everybody asked that. You're welcome. What if someone has a history of substance use? What are your thoughts on SUD diagnosis, justification, medical necessity when it comes to a client who's abstained for over 12 months with current report of triggers, thoughts, urges? You know, Shannon, maybe I'll put the diagnosis without remission so that I can get paid to help them work. You're going to use your clinical judgment on that one. I think that's a good one. Okay, I think I got to most of the questions. It's 2:55. I don't know how I did all that in 2 hours, but I wanted to give you all as much as I possibly could. I really hope I did it well. I hope I didn't do it too fast. And please give really good, clear, constructive evals so that if I'm asked to do this again, I can change things or do things better. I appreciate all of you participating. When I don't get to see faces, it's really hard. And so you will get the slides. So when I see your chats and when I see your questions, it's awesome. It helps me do this webinar format in a different way. So I'm going to go ahead and let Alyssa or Jean come back on if they need to say anything else. And I will end here.
Thank you so much, Jennifer, and thank you all for being so active in the chat and all your wonderful questions. I really, really appreciate it, and you know, we're here for you and to help you. So thank you so much for that. Before you all go, I did put some reminders in the chat for you all. You will be redirected to a very short survey. So like Jennifer said, please take some time to give us your feedback. It does allow us to continue to provide free trainings to you all, and then we will also provide that feedback back to Jennifer, as we would love to bring her back on and do some more trainings for you all. Certificates of attendance will be sent out via email to all who attended today's session in full. Please allow up to 2 weeks to receive your certificates, and if it's been 2 weeks and you still haven't received it, check your junk or spam or email us at events@chess.wis.edu. And as people have been requesting the slides, the recording and the slides will be made available on the Great Lakes ATTC website by the end of this week. I will be also sending the link to the recording and slides with your link to the certificates within 2 weeks. So I hope we see you all again on some future trainings. And if anything, reach out. And again, hope to see you again. Thank you all so much.